Welcome to the deep dive. Today we're tackling acute rheumatic fever, ARF for short.
Right.
Now, you might not have heard of it directly, but it's really quite a fascinating situation. Shows how our bodies can sometimes get their wires crossed.
And the global impact is pretty significant, too.
Definitely. So at its core, ARF is systemic. It affects multiple parts of the body, not just one spot. It's classed as a connective tissue disease.
And the trigger often is something incredibly common, a sore throat, basically.
Exactly. A group A streptococcus infection, strep throat.
Most people have had it.
Right. But here's the twist. If that strep throat isn't treated properly or at all, it can kick off this whole chain reaction, affecting joints, the heart, central nervous system, skin. It's quite far-reaching.
And the potential downstream effects, the complications, that's where it gets really serious.
Absolutely. You're looking at things like arthritis, so inflammation in the joints, carditis, inflammation of the heart itself, which is a major worry.
Yeah.
Then there's Sydenham's chorea, these involuntary movements, erythema marginatum, a specific kind of rash, and subcutaneous nodules, which are little lumps under the skin.
And it primarily hits a specific age group, doesn't it?
Yes, that's important. It mainly affects children, typically between 5 and 15 years old.
So that's the key window for awareness.
Definitely. But here's a really critical point, maybe the most critical. If you treat that initial strep throat properly with antibiotics,
You can pretty much stop ARF from developing.
exactly, you essentially eliminate the risk. It really shows how vital timely treatment for strep is.
Okay, but it's not like the ARF symptoms appear immediately after the sore throat, is it? There's a delay.
Right, there's a lag time. Usually, the rheumatic fever symptoms pop up about 1 to 3 weeks after the throat infection itself.
Okay.
And while strep throat is common here, ARF itself, well, its impact is much bigger globally, wouldn't you say?
Oh, absolutely.
Yeah.
ARF and its chronic form, rheumatic heart disease, or RHD, are much, much more common in developing countries.
Right.
Estimates are around 20 million people worldwide living with ARF or RHD. It's a huge health burden.
20 million. That's a massive number.
Yeah.
And it's a leading cause of cardiovascular death globally.
It really is. We see something like 470,000 new ARF cases each year, and around 233,000 deaths annually are linked back to ARF or RHD.
Wow.
And in some parts of the world, the rate among kids can be over 50 per 100,000. It's alarmingly high in some areas.
Those numbers just really highlight the scale of this. So what makes someone more susceptible? Are there specific risk factors?
Yeah, there are several things. Genetics seems to play a part. Some people might just be more predisposed.
Yeah.
Socioeconomic factors are huge.
Yeah.
If you don't have easy access to healthcare, that strep throat might just go untreated.
Which then increases the risk of ARF developing. Makes sense. What else?
Having recurrent URIs, upper respiratory infections, seems to increase risk. Living in developing countries, as we said, often means fewer resources all around.
For treatment and prevention.
Exactly. And also crowded living conditions.
Yeah.
That just helps strep spread more easily in the first place.
So it's this mix of individual biology and the environment people live in. Okay, let's get into the mechanism. How does strep in the throat lead to heart problems, joint problems? What's the actual trigger?
Well, it starts with that group A strep infection, the URI. Then after that 1 to 3 week gap,
The latent period.
right, the immune system kicks in, does its job, produces antibodies to fight the bacteria.
Okay, standard immune response. Sounds good so far. But there's a catch.
There's a catch. It's basically a case of mistaken identity by the immune system. Molecular mimicry, it's sometimes called.
Mistaken identity. How?
So the antibodies the body makes to target the strep bacteria. Well, parts of the strep bacteria, especially a surface protein called the M protein, look very similar to proteins in our own tissues.
Ah, so the antibodies get confused.
Precisely. They see similar looking proteins in the heart, the joints, skin, even in the basal ganglia in the brain, and they attack those tissues too.
So the defense system accidentally attacks self because it resembles the invader.
That's exactly it. And that misdirected attack causes inflammation and damage in those tissues. And that's what we see as rheumatic fever.
Fascinating, but really unfortunate for the patient. Okay, so let's break down these manifestations. Starting with the heart carditis. What does that involve?
Carditis is a big one. Happens in maybe 40 to 60% of cases. A key sign doctors listen for is a new heart murmur.
That whooshing sound.
Yeah, it indicates turbulent blood flow, maybe because a valve isn't working right due to the inflammation. We might also see cardiomegaly, the heart getting bigger.
Because it's inflamed or working too hard.
Both, potentially. And that can lead to congestive heart failure where the heart just can't pump effectively, causing fluid backup.
Serious stuff.
Definitely. You can also get pericarditis, inflammation of the sac around the heart, causes chest pain, and the valves themselves can get damaged, leading to valvular disease long term.
So the inflammation can hit different layers of the heart.
Yes. You can have rheumatic pericarditis affecting the outer sac, rheumatic myocarditis affecting the heart muscle itself that can cause fatigue, shortness of breath, and rheumatic endocarditis affecting the inner lining and especially the valves. That's where you can get damage and even little growths called vegetations on the valves.
And the long-term risk here is heart failure.
Potentially, yes. The chronic damage from carditis is what we call rheumatic heart disease, and that can lead to heart failure down the line. But it's crucial to stress, not everyone with carditis develops severe long-term problems, especially with good management.
Right, early treatment matters. Okay, let's shift to the joints. Migratory polyarthritis, what does that look like?
This affects a lot of patients, maybe 3/4 of them. Polyarthritis means multiple joints are involved, usually the big ones, knees, elbows, ankles, wrists.
Okay.
And migratory is the key word. The pain and swelling move from joint to joint. It might be the knees for a few days, then that gets better, but the elbows start hurting.
Ah, so it travels around. That's a very distinct feature.
Very characteristic, yes.
What about Sydenham's chorea? The name sounds dramatic.
It is quite distinct. Historically called St. Vitus's dance. It's a neurological thing. Affect maybe 5–10% of patients.
Okay.
It causes these involuntary, jerky, rapid movements.
Mm-hmm.
Can affect the face, hands, feet. It can look a bit like fidgeting initially, but it's uncontrollable. Sometimes comes with muscle weakness or emotional changes too.
That must be really difficult for the child. And the skin signs, nodules and a rash?
Correct. Subcutaneous nodules are found in about 10%. They're firm little lumps, painless, usually over bones or tendons, elbows, knees, wrists sometimes.
Okay.
And then erythema marginatum. That's the rash, seen in maybe 5%. It's quite unique, sort of pink or red rings or wavy lines, often with clear centers. It can come and go.
So quite a collection of possible symptoms, all stemming back to that strep infection. It really paints a picture of a systemic illness. Given all these possibilities, how do doctors actually diagnose ARF? It sounds complex.
It is like putting together a puzzle. Yeah. We use a set of guidelines called the Modified Jones Criteria. They help standardize the diagnosis by categorizing signs into major and minor.
Okay, let's start with the major ones. What are the big indicators?
The major criteria are the things we've just discussed. Carditis, the heart inflammation, migratory polyarthritis, the shifting joint pain, Sydenham's chorea, those movements, erythema marginatum, the rash, and subcutaneous nodules, the lumps.
So those are the heavy hitters, suggesting ARF strongly.
Exactly. They're more specific to rheumatic fever.
And the minor criteria, they're less specific but still add to the picture.
Right. Minor criteria include arthralgia, that's joint pain without the definite swelling and inflammation of arthritis. Fever usually over 38.5 Celsius.
Okay.
Also lab tests showing inflammation, a high ESR, erythrocyte sedimentation rate, or CRP, C-reactive protein. These are general markers, not specific to ARF, but they show the body's inflamed.
Any others?
Yes, one more. A prolonged PR interval on an ECG, the heart tracing. It suggests the electrical conduction in the heart is a bit slowed, which can happen with carditis.
So you have these major and minor lists. How do you combine them for a diagnosis?
For a first episode, you need either 2 major criteria,
Okay.
or you need 1 major criterion plus 2 minor criteria.
I got it. 2 major are 1 major and 2 minor.
But, and this is crucial, you also need evidence of a preceding Group A strep infection. The criteria alone aren't enough without linking it back to strep.
Ah, okay. How do you prove that recent strep infection, especially if the sore throat was weeks ago?
Good question. We look for things like high or rising levels of anti-strep antibodies in the blood. The ASO, anti-streptolacin O, titer is a common one.
Antibody levels.
Right. Or a positive throat culture for strep, though that might be negative by the time ARF symptoms start. A recent history of scarlet fever also counts as evidence. Basically, you need lab or strong clinical evidence that strep was there recently.
Makes sense. Clinical picture plus the strep link. What if someone's had ARF before? Is diagnosing a recurrence different?
Yes, the bar is slightly lower for a recurrence. You might diagnose it with just 1 major criterion, or even just 2 minor criteria, if you also have that evidence of recent strep infection. The assumption is they're more susceptible.
Okay, that follows. So once the diagnosis is confirmed, what's the treatment plan? What are the main goals?
The goals are pretty broad. You want to relieve the current symptoms, obviously, manage any complications like carditis, eradicate any lingering strep bacteria,
Right.
and crucially prevent it from happening again. Plus, just improve the patient's quality of life overall.
Sounds comprehensive. What about non-medication approaches? Is bed rest still a thing?
It often is, yes, especially initially if there's concern about carditis.
Yeah.
Reducing physical activity helps lessen the strain on the heart and allows for monitoring.
Okay.
Sometimes doctors might hold off on anti-inflammatories right at the start, just for a day or so, to see the full picture of the illness before starting treatment. Emotional support is really key too, particularly for kids with chorea. Those movements can be scary and frustrating. In education, making sure the family understands the illness, why long-term treatment is needed, how to prevent it coming back, that's vital.
That supportive side seems really important. Okay, medications. How do you tackle the strep bacteria itself?
Antibiotics are essential, even if the throat culture is negative, to ensure any remaining strep is gone. The standard is usually benzathine penicillin G.
An injection?
Yes, a single intramuscular injection. The dose depends on weight, 1.2 million units. For those over 27 kilograms, 600,000 units if they're 27 kilograms or less.
And this also helps prevent future episodes, right?
Exactly. That initial dose is treatment, but benzathine penicillin injections are also the cornerstone of long-term prophylaxis prevention of recurrence.
Are there risks with the injection?
There's always a small risk of allergic reaction, potentially severe anaphylaxis, so it needs to be given where emergency backup like adrenaline is available.
Okay. What if someone's allergic to penicillin?
There are good alternatives. Macrolide antibiotics like erythromycin, azithromycin, or clarithromycin can be used. Clindamycin is another option. The key is completing the full course to eradicate the strep.
And there are oral options too, even if not allergic, like amoxicillin or cephalexin.
Yes, for the initial eradication, oral options like amoxicillin, cephalexin, or even oral penicillin V for 10 days are alternatives, though the single IM injection is often preferred for ensuring completion. For long-term prophylaxis, however, the IM benzathine penicillin is strongly preferred for reliability.
Got it. Now, what about treating the inflammation itself? The arthritis, the carditis?
For the migratory polyarthritis, and for carditis that's mild to moderate without major heart enlargement, we typically use anti-inflammatory drugs.
Like aspirin.
Aspirin is often the first choice, yes. Usually started at a higher dose for a few days to get the inflammation down quickly, then tapered to a lower dose for several weeks, maybe 4 weeks or so.
And if aspirin isn't tolerated or doesn't work?
Naproxen is another NSAI option. If those aren't effective enough, or if the carditis is more severe, then we move to corticosteroids.
Like prednisolone.
Exactly. For more severe carditis, especially with cardiomegaly or signs of heart failure, prednisolone is the go-to.
How is that used?
Usually a higher dose for 2-3 weeks to really suppress the inflammation. Then it's tapered down gradually, maybe reducing the dose by about 25% each week.
Okay.
And often, as the steroid is being tapered down, aspirin is started at a maintenance dose and continued for a total of about 6 weeks of anti-inflammatory therapy. We monitor inflammatory markers like ESR to guide the taper.
What about those other heart medications you mentioned in the outline, digoxin, furosemide?
Right. Those come into play with moderate to severe carditis, especially if there's heart enlargement, heart block, or congestive heart failure.
Alongside the steroids?
Yes. Prednisolone tackles the inflammation. Digoxin helps the heart muscle pump more effectively. Furosemide is a diuretic, helps get rid of excess fluid that builds up in heart failure.
So it's a multi-drug approach for severe cases. Okay, let's circle back to preventing recurrent secondary prophylaxis. You mentioned the benzathine penicillin injections. How long do people need those? It varies, right?
It does vary, based mainly on the severity of the first episode, particularly the heart involvement. The American Heart Association has guidelines.
Okay.
If someone had ARF without any carditis, they generally need prophylaxis for 5 years after the last attack or are until they turn 21. Wait, let me check that.
Yeah.
Yes, it's typically until age 21 or 5 years, whichever is longer.
Okay, 5 years or age 21, whichever's longer, for no carditis. What if they did have carditis?
If they had carditis, but if there's no lasting valve damage or maybe just mild residual mitral regurgitation, then it's longer. 10 years after the last attack or until age 21. Actually, let me correct that. The guideline often suggests until age 25 for these groups, or the duration, 5 or 10 years, whichever is longer. Let me reconfirm the age threshold. Yes, recent updates often lean towards 25 for these moderate risk groups, or the duration, whichever is longer.
Okay, so 10 years or potentially age 25 for carditis without major lasting damage.
Right. But if they have persistent valve disease, or if they've had heart valve surgery because of rheumatic heart disease,
then it's much longer.
Then it's often lifelong prophylaxis, or at least until age 40. The risk of a recurrence causing more damage is just too high.
Lifelong, potentially. Wow. And those injections are usually every 3-4 weeks.
Yes, every 3 or 4 weeks is standard for benzathine penicillin to keep a steady protective level in the blood.
That's a serious long-term commitment. Okay, quickly, managing the chorea, you said anti-inflammatories don't help much there.
Correct. For Sydemus chorea, it's more about managing the neurological symptoms. Sedatives like phenobarbital or diazepam might be used initially.
To calm the movements.
Yes. If those aren't enough, stronger meds like haloperidol or clonazepam might be tried. Treatment might last 3-4 months. Sometimes Pimozide is considered if things drag on.
So, a different approach for the neurological part. And finally, what about follow-up? How often do patients need to be seen?
Regular follow-up is key, maybe every 3 to 6 months, depending on their status.
Right.
To monitor for any lingering issues, check for signs of recurrence, make sure prophylaxis is happening.
And to reassess if things aren't improving as expected.
Absolutely. If someone doesn't respond to anti-inflammatories quickly, you have to rethink the diagnosis.
Yeah.
You also watch for rebound inflammation when meds are stopped. And any sore throat needs prompt attention and follow-up if it doesn't get better fast.
Constant vigilance, really. Okay, this has been incredibly thorough. To wrap up, what are the absolute key messages you want people to take away from this deep dive?
I think the number one thing is treat strep throat promptly and properly. Yeah, it's the best prevention we have.
Right.
Second, understand that ARF is this complex immune reaction. It's not the bacteria directly damaging the heart or joints. It's the body's response gone wrong.
That cross-reactivity.
Exactly. Third, adherence to treatment, especially the long-term prophylaxis, is absolutely critical to prevent devastating long-term heart damage, rheumatic heart disease.
Don't skip those shots.
Don't skip them. And finally, remember, this is still a major global health problem, especially where access to basic health care is limited.
It really is sobering. Thinking how a common sore throat, if missed or untreated, can ultimately lead to lifelong heart problems for millions worldwide, it definitely makes you pause. It raises questions, doesn't it, about that intricate connection between infections, our immune system, and long-term health. What other connections are we missing? Something to think about.
Thanks for joining us on this deep dive.